we set up a mass vaccination campaign for meningitis at the high school so everyone could get vaccinated. And we had to have a town hall meeting just kind of explaining this to the entire town because
Dr. Clarissa Hoff, hello and welcome to eShadowing.
Hi, thank you for having me. I
Thanks.
really appreciate being here today.
Thanks for joining me. I'm excited to chat with you. Family medicine physician, preventive medicine physician as well, former Premed, as those in the know, the Premed residency director. So I'm excited to chat with you about kind of your journey to those specialties and hopefully help those who are watching here today understand a little bit about what's going on out in the world of primary care and community. I think the biggest question when a student is joining, and there's 70 or so jumping on right now, the biggest question is going to be, what the heck is preventive medicine? Isn't all medicine preventive?
Prevention, the 10-second elevator speech is using your skills as a physician in the public health world, because those two, public health and clinical medicine, don't speak to each other, and really they should be tightly intertwined. But unfortunately they're very siloed, and so you're one of the very few physicians that's trained to speak both languages and can kind of like bridge the gap between the two, because you do understand clinical medicine and you do understand public health and how to make those two actually work together. And preventative medicine is honestly, pure preventative medicine is honestly about preventing diabetes and preventing, addiction and preventing lung cancer and all that. So hopefully, the rest of us have a lighter patient load because we're all overworked and overburdened and the system is too stressed. And if we, the most recent stats coming out is that the kids born now might be the first generation to have a shorter lifespan than their parents. And it's really due to things like obesity and drug use and all these things that our modern society has created as a part of our built environment, but don't need to exist, And so that's where preventative medicine comes in, and I'm also a family medicine doctor as well. And so I love primary care. But preventive medicine, primary care is amazing because you get an everyday relationship with your patient. But preventive medicine has allowed me to expand that impact beyond just the individual patient to like community, statewide. I mean, with COVID, you've seen the national impact that prevention can have. Once that vaccine came out, the mass, and the vaccine campaign, educating the public, the massive drop in numbers and our ability, like our hospitals weren't overflowing anymore. We didn't have to split ventilators between two patients. All those types of things. That was all prevention.
It's interesting, as someone who now runs a pretty large business, I often get stuck between working in the business and working on the business. And I almost compare, as you were talking and thinking about it, I almost consider family medicine as working in the business, right? You're just there daily grinding. You don't have time to pick your head up and look around and see what's going on, because you constantly have patients that are symptoms of this bigger thing. And preventive medicine is this opportunity to work on the business, this community, to potentially look at systems that are broken, policies that need to be updated to fix the downstream effects, where you as a family medicine doc are seeing all the downstream effects of policies and systems and environment and everything else. Is that potentially a good analogy?
Yeah. We work on the system of medicine. We don't, ideally for, we get above the 100,000 foot view.
Yeah.
Another fun fact about preventive medicine is we're consistently ranked the happiest field in medicine.
It's because you don't have all the charting.
Yeah, maybe. It's us, then dermatology. And then it goes down from there.
That's funny. I don't think I knew that.
And I think it is. I think it's because, we have a very good quality of life. I mean, there's not a whole lot of preventative health emergencies.
Yep.
COVID was probably our one exception. But at the end of the day, like, you can honestly go home and say, like, I helped a lot of people today. I stopped an outbreak that saved an entire town from getting meningitis. I can actually tell you about that.
Yeah. Well, let's actually potentially think about it in current real world ramifications. How much do you think preventive medicine specialists are in and around this train derailment of vinyl chloride in Ohio? And what are they doing for that community?
Oh, they have preventive medicine specialists, like, specifically trained in environmental medicine and toxicology. That's one of our subspecialties. Mm-hmm. And so, that they're there. I mean, if the CDC, NIOSH is a subdivision of the CDC, they're all there, helping clean up and they will now start tracking all those people who have been exposed, to make sure that there's no further poor outcomes. And it could possibly be years, if not decades long, depending on what kind of outcomes become of this. And that will all be preventative medicine, or people who have preventative medicine training, even if they didn't necessarily go through the residency program. They might have got similar training, like through the CDC and the Epidemiologic Intelligence Service and things like that. Yeah. And they will help with, future policy planning. They'll work with, like, the engineers. They'll work with, it's very a collaborative field. You don't just work with doctors, which is really fun. You work with, like, when a train derails, you're working with the engineers. You're working with, you're working with all the chemistry, anyone who's involved with the, chemistry PhDs, trying to figure out, like, how best to neutralize this. You're working with environmental impact specialists, because animals, how it affects the animals and plants around there, is going to be important as well, because you need to coordinate all that. And preventive medicine takes all that into account, because it's not just the environment affects people. Yeah. And so you have to include that in how you respond to any situation. Yeah. And so it's pretty
interesting.
It's pretty impressive.
I think talking to a lot of pre-meds, there's always a lot of kind of rose-colored glasses of students coming in saying, I want to fix the community. I want to impact the community. And all I think about is preventive medicine. Like, that's perfect for you. But nobody goes into preventive medicine. Why is it such an unknown specialty out there?
I don't think it doesn't, our system is set up to pay to fix broken things. It's not set up to pay to stop them from breaking. Yeah. And because we don't make money, that's not where the focus is. And so it doesn't get promoted really well. Like, a neurosurgeon brings in huge amounts of dollars. But if you're seeing a neurosurgeon, something's already gone very wrong, And so you know, when you're not flashing a lot of shiny dollars around, your field just doesn't get promoted very well. And so we just have a system that doesn't focus on prevention. Now, hopefully that's changing. A lot of the insurance companies and things like that and other payers are starting to realize it's really expensive to pay to fix everything all the time. And it's a whole lot cheaper to pay to prevent it.
Yeah.
And so they're starting to change their payer models, which is starting to bring preventive medicine and, quite frankly, more of the primary care specialties like family medicine up to the forefront, who have been kind of like shoved to the background in the past. And so it's really and COVID has hopefully kind of brought preventive medicine up to the forefront as well. And we kind of have this unfortunate kind of quirk in the system. If we're doing our job right, you never know we were there, because if you never got lung cancer or you never, because you were never exposed to radon in the home, or
I got my radon detector right here.
Oh, really?
Oh yeah. Awesome. I work in the basement. I got to make sure that I'm not getting radon.
Good for you. Or you didn't have, you know, like, you're never going to thank someone for all the diseases you never got, you know? And so, like, it's pretty, you know, and so people don't realize it until something goes very wrong. Like, COVID exposed a lot of weakness in our public health infrastructure. And all of a sudden, everyone was mad that we didn't have everything up and running. Well, every public health and preventive medicine physician was like, well, we've been telling you this for decades now.
Told you so.
But no one wanted to pay for it.
Yeah.
So here we are.
Here we are. Let's jump in. You have a brief little presentation here. And then we'll have lots of time for Q&A, maybe a little bit of a case presentation of what a preventive medicine patient may look like. So let's go ahead and talk through this.
Yeah, so preventive medicine and family medicine. So family medicine, you enter kind of through a traditional residency program. You complete a med school, you apply through the traditional match, you get into family medicine, and it's 3 years of residency. And then you graduate as a board eligible or board certified family medicine residency. Preventive medicine is 3 years as well. And I'll get into the difference in how you complete that program. If you want to do family medicine and preventive medicine combined, you can. It doesn't have to be 6 years total. You can actually shorten it. It can be reduced you can reduce the preventive medicine side of it to a 1 to 2 year program, depending on if you have your MPH kind of completed or not. So next slide. Whoops. Preventive medicine, if you're going to do straight preventive medicine, what you have to do is an intern year. It can honestly be done in any specialty that has direct patient care at an ACGME approved program. So whether it's family medicine, surgery, dermatology, ophthalmology, psychiatry, as long as you complete the full year and you get credit for your intern year, and you have at least 10 months of direct patient care, you can, during your intern year, you can apply for the preventive medicine residency program. I kind of make that point specifically because a lot of people think maybe a research year could count for that, and unfortunately it doesn't. So when you apply for your preventive medicine residency during your intern year, it's a 2-year program. You get your MPH, you do it during your preventive medicine residency program. Most programs will do it kind of concurrently online. Preventive medicine doesn't really have call, so your MPH online during the evenings and weekends acts as your call. So our residency program tends to have a lot better hours than a lot of other programs. Not to say that you don't have a lot of work and you aren't very busy. It's just you have a lot more ability, a lot more control over your schedule because you decide how you're going to do the MPH and all that.
Yeah.
And because the program is a lot of public health, you don't always have direct patient care, but you are required to do 8 weeks of direct patient care per PGY year. PGY stands for postgraduate year for pre-meds. They'll sometimes say HO, which is house officer. What's another way they say it? I think those are the two main ones.
Yeah, that's typically it.
Yeah.
Okay.
It's just different ways they refer to residents. And so when you apply for a preventive medicine residency program, you don't apply through the standard match. You actually apply through the American College of Preventive Medicine through the standardized acceptance program. There's absolutely no fee. You can apply to as many programs as you want. And you can just go to the American College of Preventive Medicine website and look that up to see where to apply.
That's nice.
Yeah.
Oh, that's weird. Backwards.
Yeah, that's all right. So I'm going to show you kind of like what my residency program looked like when I ran it up until actually just a couple months ago when I transitioned out. So your PGY 2 year, remember you did your intern year someplace else. We had our residents do, so that way your first year with me, you did 2 months of direct patient care at a VA. They did it in like primary care or addiction medicine or pain management, something that was, kind of a subspecialty of preventive medicine. And then they would do 3 months in quality improvement, which is a very important aspect of preventive medicine. One resident in our program did it on, in their women's primary care clinic at the VA, there was a lot of overprescribing, and she reduced overprescribing by 30% at the VA and saved them tens of thousands of dollars, which really put our program in a good light at the VA because they like saving money. And then she did another 1 month elective. And then she did 3 months of the Office of Public Health in infectious disease and environmental epidemiology. So when I was there, we can do a little mini case study, and I did my infectious disease epidemiology rotation. I did a lot of things where I would, we updated the antibiogram for the state, which is where we look at all the bacterial cultures in the state and see what they're sensitive to, which antibiotics they're sensitive to, and which ones they are resistant to. And then we publish all that data for all the hospitals and doctors to see. So they know, okay, if my patient has a UTI with this bacteria, they're most likely going to be sensitive to these drugs. And I definitely don't want to prescribe these drugs, Bactrim, because most of the E. coli in Louisiana is resistant to Bactrim, and it won't treat the infection. But one of the big things that happened while I was there, this was well before COVID. I won't say how long before COVID to give away my age, but we had what happened was a young teenager got sick and died. So what had happened is he was really young, he was fit, he played multiple sports at school, and he was doing fine. He was running around all day Friday. Saturday, he went to a church lock-in. Do you know what that is? They're very common in the South. I don't know if everyone knows what church lock-ins are. We did them in my Midwest church at home. But what it is, to keep kids out of trouble, is the youth pastor and a bunch of other church leaders we'll have all the teenagers from the, I see hearts on the comments, of all the teenagers from the church come in on a Friday night. They literally lock the doors of the church and they just entertain them all night with like movies, drinks, sodas, and whatever to keep them from doing other things. Usually there's like worship and Bible study, but they all share drinks. They all share food. They're all doing very close contact all night long. Someone had a lock-in last week. You know exactly what I'm talking about. He gets out from his lock-in. He goes and plays in a baseball tournament. That day, he starts feeling bad. He starts getting sick enough to have to go to the hospital. He's in a very rural, small town. He's too sick for them to care for him while he's there. They they try and transport him to a larger facility, and he dies on the way.
Wow.
Yeah. So the
herpes encephalitis.
Close. Very close. So what happens here results in where good policy and people knowing their policy is the hospital that was supposed to receive him said, we're not reporting him because we never got him. He's not our patient. The hospital that
we don't want to do the paperwork. That's what they said.
Yeah, we don't want to go do the paperwork. The hospital that sent him said, you already accepted him. He's your patient, so we're not reporting him. So he didn't get reported, his death, which by law has to be reported like immediately because it was a sudden death of a child that should not have died. He was literally playing baseball that morning. Didn't get reported for several days. And so we found out late after they had done a spinal tap on him and they grew out meningococcal meningitis, which, yeah, you're shaking your head because if everyone here knows, meningococcal meningitis is a bacterial infection of the membranes of the spine and brain. It's highly contagious, highly deadly, and needs to be and is highly preventable through vaccines and prophylactic antibiotics.
Yep.
And it is contagious before you are symptomatic. So guess who was exposed to
healthcare workers?
No, healthcare
and
workers.
All of the other lock-in people. All the healthcare workers are vaccinated, hopefully.
Because it's not spread through the air, but it is spread through saliva. In close proximity. It's what we call droplets.
Yep.
You know. So technically it is through the air, but that's more like if they sneeze a droplet in your face or something like that. So every one of those kids where they're in a close proximity were locked in with him, were exposed to meningitis. But it was several days later. And all those kids who had been exposed, because it was a small town, all went back to the same small town high school. And so we didn't find out until everyone was already back at school.
That's fun.
Yeah. So the principal finds out, immediately cancels school, sends everyone home. We have to do extensive contact tracing and figure out where this kid might have gotten meningitis from.
Yeah. And your contact tracing, I'm assuming, is like, where in the auditorium were you? Were you in this corner, that corner? What other people are around you?
How big was this church? Mm-hmm. How many kids were there? We need to know everyone. Because every single person that was in that lockdown, had to get antibiotic prophylaxis immediately.
Yeah.
And in fact, the one girl who for whatever reason, did not take her antibiotics, ended up getting meningitis and ended up in the ICU. She did live, but she lost several limbs.
Oh,
So other people at the school didn't necessarily need antibiotic prophylaxis. We did tell them if they wanted to, out of abundance of caution, like these are the antibiotics you can go get. You just don't necessarily get them from the health department because you don't meet criteria of like close contact. And then we set up a mass vaccination campaign for meningitis at the high school so everyone could get vaccinated. And we had to have a town hall meeting just kind of explaining this to the entire town, because the entire town, it was a small town, but the entire town was at risk because every single one of those kids, if one kid at that high school got sick and potentially exposed the high school, then it was basically everyone in the town would potentially, we could have had a huge meningitis outbreak in the town. And so we kind of backstepping now. You know, we'd done the major work of like just ensuring that it didn't spread out through the thing. One, we clarified the policy of who has to report. You don't wait till the cultures come out for 3 to 5 days later, like when a kid dies. Two, trying to figure out where he got it from. He actually had a family member who had a atypical presentation of meningitis. He was probably a user, got sick. They didn't know why he was sick. They couldn't figure it out. They did spinal tap him at some point in time, but took a really long time to grow out. And they didn't find out until like afterwards, that after he had died, that it was meningitis. And they didn't realize that he had contact with this kid until after the kid had already died. So that wasn't necessarily a failure to report on that side, but they also had to go back to this other family member and ensure that there was no other outbreaks associated with him, and do all of the contact tracing around him to make sure there was no other secondary outbreaks. But yeah, that was a completely fascinating project that I worked on. I mean, it was horrible for the family, but it was also really wonderful to see how many lives you can save. You know, no one had to get sick after that. You know, we went in, it was a simple, like, here's a couple of pills, everyone get their shots, and an entire town was saved from some very severe consequences, you know.
And again, from a community aspect, from a policy standpoint, you have an event that happens, and you as preventive medicine, yes, you handle the immediate issue and consequences, but then you're, I'm assuming, doing some postmortem stuff, some looking back, where were there systematic failures in this process that for the next potential outbreak, we're preventing it at the very beginning, right?
Yeah. So we had to figure out, did we miss something because he wasn't case 0. There was a case before him, and we had to figure out, did we miss something there? And then the whole debacle of no one reported it for days because it's not my paperwork, it's your paperwork. Argument, which is unfortunately all too common in healthcare.
Are there, again, from a policy standpoint, are there consequences for hospitals that don't report stuff?
I mean, it just depends on how the policy and the law is written, right? And so, and it also depends on if someone's going to bother to enforce it, because it requires someone willing to do that, usually a district attorney or something like that to go after it.
Yeah.
So,
wow.
But yeah,
fascinating.
That was my environmental, and environmental epidemiology is fascinating as well. I did anything from like, one of my residents is working on environmental asthma triggers, and especially in low income families who end up in the ER a lot. And so they're working on helping them reduce environmental asthma triggers in their homes, so that they can reduce, medication use and ER visits. And then you do, one of the things that we have at, every preventive medicine residency program is different. But one of the things that we have is kind of this: you do 3 months in your PGY 2-year and 6 months in your PGY 3-year is a public health officer rotation, which I'll get more into on the next slide in a bit. But the PGY 3-year, you do 6 months, your public health officer rotation, 4 months electives. Usually we do ours at the VA. And then we do 2 months of rural medicine out in Alexandria, VA. Anyone who's familiar with Louisiana geography knows that's kind of way out there. Our residents usually have to bring their own hotspot to get internet. But it's really fascinating to work with a rural population and see what their challenges are. It's because it's completely different than what people in the, it's a completely added set of challenges. So here's our public health officer rotation is done at the Louisiana State Office of Public Health. And basically the resident is gifted the state of Louisiana and all the resources of the Office of Public Health. And they have 9 months to kind of create a public health project or work in a public health department that interests them. During COVID, one of my residents worked in the vaccine, like tracking the vaccine in Louisiana, distribution, working in tracking if there's any adverse reactions in the state of Louisiana. Another one, she was more into the infectious disease side of it. And so she worked with outbreaks in the nursing home and setting up all the nursing home policies. And then when they started to reopen the schools, she helped literally develop the state policies on how to reopen the schools.
Wow.
And worked on outbreaks in the schools. Not COVID related. Like one of my residents is, working on the policy for asthma prevention in the state. She really is interested in policy. So she's getting all the data together and being like, it's a policy paper that she's writing for legislatures to read and be like, and so that they can go through and say, these are the policies and laws that we need to put in the state in order to hopefully reduce asthma in the state of Louisiana. Like we need to require landlords to mediate all mold in the households. They're not allowed to just allow mold to grow freely, or, they have to use certain types of flooring or change the carpet so many years, so often, to prevent that type of thing. Or, after ER visits, children need to have, home, like after so many ER visits, children need to have like home education plans or things like that. But she's looking at all that evidence and trying to put it together in a way that's understandable to legislatures so they can just move it over into legislation and public health policy and actually make it functional for the state.
Wow, that's cool.
So, yeah. But those take a long time. That's not just a hop into the ER for 2 weeks and then hop back out. You really have to spend 9 months doing it.
Yeah.
Masters in public health, like I said, it's done concurrently at, some programs will actually set aside dedicated time to do it in person. A lot of programs, you just do it online or in evenings and weekends. You always have to do it at a CEF approved school, which is the Council on Education for Public Health. There's a lot of, just be careful, because there's a lot of like Phoenix online programs that will tell you they offer a public health degree, but it's really not approved by any credible organization. And so it's basically worthless and they will take your money.
Yeah.
So just make sure you go, if you ever get an MPH, just go to CEF and see if it's approved by CEF first before spending any money. And people always ask me, why not just get an MPH?
Yeah.
Why do you have to do preventive medicine? And it's kind of like saying like, well, I mean, an MPH is the book knowledge. Preventive medicine is the actual hands-on experience. You know, I can read all the books about how to run a vent and treat a patient in the ICU, but no one will want me to actually be in the ICU unless I've trained in the ICU under someone who knows what they're doing first.
Yeah, definitely.
So that, I mean, you really have to have that hands-on experience in preventative medicine to be true value in public health, and as a physician trained in public health. So you have to have your MPH or an equivalent degree. Like some people will get a master's in science and epidemiology or master's in healthcare administration. But no matter what, kind of your core requirements is you have to have classes in epidemiology, biostats, public health administration, behavioral health, and occupational environmental health, because that's the foundation of public health. And prevent, you know, we do lectures half day a week, you know, so that's, you know, in addition to doing MPH stuff, other programs will just, you know, say the MPH is sufficient. You don't have to do lectures, but the MPH doesn't always cover everything you need to know for your board exams. So
yeah,
we add on. And then, you know, residents tend to do a lot of QI projects and research, and you know, all those outbreak investigations you can write up and publish at the CDC and their Morbidity and Mortality Weekly and things like that. And so if you like research, getting an MPH in preventive medicine is a great way to do it. Like he graduated well before me, but we have a you know, one of our Tulane graduates, he thought he was going to be an orthopedic, and then he realized what he really liked was exercise sports science. So he did his preventive medicine residency because he wanted people to exercise. Like, and so he got his preventive medicine residency. He did, you know, focus on epidemiology and biostats at his MPH, so he could really work on the so his research skills were up to par. And then when he graduated, that's what he did, is he did exercise science to really get people exercising, you know, like how much do you have to exercise? What's the best way to exercise, you know?
That's cool.
Things like that. Yeah. So our graduates, what do they do? Some of our official fellowships are addiction medicine, hyperbaric and dive medicine, toxicology, clinical informatics. Other subspecialties are occupational medicine and aerospace medicine. Some residents will go into obesity or lifestyle or medicine, pharmaceutical industry. You know, there's a lot of safety and managing the safety and just managing the studies that needs to happen.
Yeah.
You know, one of my co-residents, when I was in the program, she went into, she's a safety officer at one of the preventive medicine, or at one of the pharmaceutical companies. Sorry, I'm so backlit right now. It's very shiny. at one of the pharmaceutical companies. And whenever they release a drug in her department, to the public, she has to track it and make sure there's no poor outcomes associated with it. You know, a ton of our residents do state and local office of public health. The Louisiana State Officer of Public Health was a preventive medicine resident. Currently, one of our graduates consults with the Louisiana State Office of Public Health on all their public health issues. Obviously, the CDC has a ton of public health officers who are preventive medicine trained. Military is very preventive medicine focused because they don't want their soldiers getting sick in the field.
Yep.
Another colleague of mine who graduated with me was very, she is Navy and she has a really robust career. Like she'll be the vaccine director for a base, which sounds boring, but when everyone is going to internationally to all different countries all over the world, you have to know every single tropical disease there possibly could be, and if it's vaccine preventable. A lot of people are medical directors at like federally qualified health centers and other community centers. And so it's, someone said lifestyle medicine. Yeah, lifestyle medicine, getting to that one, is more of a direct patient care where you see patients in the clinic one-on-one. And what you do is you focus on diet, nutrition, stress management, exercise, in order to prevent or treat disease. Some lifestyle medicine practitioners will take diabetics, help them learn a healthy lifestyle and diet, help them lose weight, and actually reduce, if not take them off all medications for their diabetes, just through weight loss and a healthy diet and exercising. So, and I said I do both because I like both, and I said you can shorten it. So if you already have an MPH, which a lot of physicians already do, and you do 3 years of family medicine residency, and you have at least 50% of an MPH or more completed, you only have to do 1 year of preventive medicine training in order to become board eligible for preventive medicine. If you don't have an MPH, you do 3 years of family medicine residency, you only have to do 2 more years of preventive medicine for a total of 5 years total. And honestly, if you've completed any other residency before this, like I knew one of my colleagues, she did radiology and she fell in love with preventing breast cancer, and she needed to expand her skills to program, to community programming. So she did a preventive medicine residency program and focused all her time on working in breast cancer prevention and increasing mammogram screening. So you honestly can come from any residency program. I just happen to be family medicine and Premed combined.
So one of the questions is, can Premed be combined with OBGYN or other specialties? So there's the answer.
Yes.
Right.
Oh yeah, for sure. And it's usually easier to do it afterwards, just because of that intern year requirement anyways. I did it backwards. I was in OBGYN. I got very burnt out quickly, finished my intern year and did preventative medicine.
Yeah.
And then there was a program in the city right next door to me in family medicine that had a 2nd-year position open, and they said, hey, why don't you come over and we'll give you 10 months credit between OBGYN and preventive medicem, so you don't have to do your intern year over again. And I was like,
sold.
I'm taking that deal. I will never get another chance to do that. And so that's how I ended up family medicine board certified too.
Nice.
So
does never has to be a straight line.
No, it does not have to be a straight line. I did not do medicine in a straight line. I was going to be a vet, switched at the last moment.
Wow. Wow.
So,
for those of you watching, if you have a question, you want to come on, raise your hand. I'll bring you on, or I'll unmute you so you can ask a question. Some other questions that are in here. So which hospital was required to report that case earlier? Do you remember? Do you know?
I don't remember which one was required to report.
Okay.
I think it was the receiving hospital, because they had, like, once they accepted the case, it was their patient, even though he hadn't gotten there yet.
Yep.
And you know, they at least had to report that there was, you know, there's laws about reporting unusual deaths, which is like any young person that dies, or any apparent murder, or, you know, someone that dies suddenly for strange reasons, you know, or unexpected reasons, but she definitely would fit the young and unexpected.
Yeah. Here's an interesting question, and I'll rephrase the question a little bit. Specifically for Premed, how much insurance involvement is there, or is there any?
If you're not directly taking care of patients, there is no insurance.
Woohoo!
I mean,
but that also means, where's the money coming from?
Yeah. If you are directly taking care of patients, then it really just depends on what you're doing. A lot of time, lifestyle medicine, you can work in a primary care setting and do it that way. And you work with primary care physicians, and you're like, hey, I'll take your poorly controlled diabetics and CHF patients, and I will get them back on the right track and like send them back to you. If you want a more concierge service where, you know, you run more of like an obesity weight loss clinic and you want to cash pay, you never have to deal with insurance. But then you're working with a specific population that's can afford cash pay only. So it really just depends on how you want to set up your model and how much bureaucracy you kind of want to put yourself through. You know, working, one comes with probable benefits, the other one probably comes with.
Takara has a interesting question. In which ways does preventive care differ from genetic counseling? So just to make sure everyone understands, right? There are genetic counselors who are not physicians, and then there are medical geneticists who are physicians. That's very different than preventive medicine, right? Medical geneticists have very specific knowledge around genetics and birth differences and all of that stuff. My assumption is that potentially there's some overlap if a medical geneticist at a specific institution goes, why are we seeing so many of these birth defects? What's going on? And hey, Premed friends, come do some analysis.
If a medical geneticist suddenly sees a spike in a birth defect that is unusual, they will call Premed or the Office of Public Health, where the Premed physicians reside, and say, this is happening, we need to know why. And then the preventive medicine will come out with their epidemiology and start working, you know. And if it all clusters around one factory or downstream from one factory, you got a starting point.
Then Sarah,
they all tend to...
Aaron Brockovich comes out, and
then Aaron Brockovich comes out.
You don't want to get on Aaron's bad side.
Well, then laws and politicians get involved, and sometimes it gets a little bit more difficult. But and there are preventive medicine specialists who will basically do just environmental exposure and toxicology and things like that. You can get very specialized in preventive medicine, or you could stay very generalized. I've never had a resident take the same path once.
Yeah,
you know,
it's really cool.
Mm-hmm.
Another question, differences between Premed and functional med. Now, I will clarify, a lot of people on social media online who call themselves functional medicine doctors or functional medicine physicians are not physicians in our sense of the word MD-DOs. They are chiropractors or naturopathic physicians
Mm-hmm.
who like to call themselves functional medicine doctors. But there is a subspecialty out there that some MD-DO physicians are calling functional medicine. Very similar, I think, to lifestyle medicine, probably.
Yeah. Like lifestyle medicine focuses kind of on the like macro, more like exercise, nutrition, in eating fruits and vegetables and things like that. Whereas functional medicine focuses, like they gone into a lot of the science of like micronutrients and supplements and things like that, which, you know, some of it has evidence behind it, and some of it is still based off of bench research and hasn't been moved out into actual human testing. So they extrapolate some of the bench research into, well, if it works on the bench, then it must work in humans, which is just not always true. You know?
No. If only.
Yeah, if only. So, you know, you just have to be careful with functional medicine and who's saying what. Yeah. Because a lot of people are claiming to be functional medicine doctors, like you said. Yeah. And claiming evidence, but they're misusing the evidence.
The first thing I go to is, what are they selling?
Yeah. Are they selling a bunch of supplements that makes them rich?
Yeah. Yeah, that's the first red flag. So be careful there. Very cool. Any other questions? Let's see. Not there. Anything. Any parting words of wisdom for the audience to maybe what's the best next step for someone early on in their medical path to go explore PrevMed?
Well, I would say the American College of Preventive Medicine, it's really cheap. I think like $25 for maybe free for medical students to join.
Nice.
They have really great conferences. And I would look to see what they have to offer. See if you can set up rotations, like elective rotations in the Office of Public Health or in community centers, or quality improvement and things like that, and just see if that's something that really resonates with you. I also say with preventive medicine, you know, everyone, you know, it's something you can always come. I don't mean this as in like, please, you know, always put it on the back burner, but like, it's always something you can come back to. Yeah. Because it is a fantastic transition career, like transitional, like a transition, what was I going to say? Midlife transition career.
It's a burnout option.
And it's not a bad thing either.
No.
You need a lot of good clinical experience and then being like, no, I need to move out. I need to take my wisdom as a clinician and move this out into the community. Yeah. And really, you know, like if you're a burnt out ER doctor and you're like, I'm tired of treating gunshot wounds, I want to prevent them, do preventative medicine. Yeah. Perfect. You know, and really, you know, move, and you can take a really amazing skill set and make it even better, and make it work for a lot more people than just the person who's bleeding out in front of you. Yep. You know.
Yeah. Kevin says, I think it's better and cheaper to prevent disease than to have to deal with the burden. There's no thinking there, Kevin. That is a factual statement.
That is 100% true. That is 100% true. Yep. And yeah, That is why I did it. I loved it.
What's the saying? An ounce of prevention is a
worth
pound of
cure.
Yeah.
Yeah.
Yep.
Yep.
There it is.
And it is. And there's, if anything, I suffer from prevention ADHD because there's just so many things you could focus on and you could work with and do.
Yeah.
It's hard to pick.
Well, Dr. Clarissa Hoff, thank you so much for taking some time to join us today and share a little bit about the Premed world.
Thank you. I appreciate it.
Thanks for everyone for coming. Have a wonderful day. We'll see you not next week. I'm traveling out of town next week. The week after. Bye, everyone.